Good afternoon, everyone. I'm Dr. Naga from Navya. I welcome you, all of you for this webinar of the day, that is current perspectives on acute myeloid leukemia management. With us, we have our panel members, Dr. Hasmukh Jain and Dr. Lingaraj Naik. I welcome you both, sir, to this webinar and thank you for accepting our invitation. So, before going for the webinar discussion, I'd like to talk few points about the experts, and then we will go on to discuss about the cases. So the flow will be like this. We will have the introductions, and then we will have the case presentation, and case presentation will be followed by question answer session where you can ask your questions. Meanwhile, if you have any questions for the experts to respond, you can also mention it in the chat box so that they can respond to the queries when they are giving their expert comments. So, and with this introduction, I would like to go to the next slide. So, I welcome Dr. Hasmukh Jain and Dr. Lingaraj Naik. Dr. Hasmukh Jain is the professor of medical oncology, Tata Memorial Center, Mumbai. He has more than 10 years of experience in adult hematolymphoid oncology. He has performed the first indigenously developed Carticel Therapy developed by TMH and IIT Mumbai. So that is the most spoken about thing here in this expertise. So here the cost of Carticel therapy has been brought down from 4 crores to 40 lakhs. I think that is what I read in the media, and I think we will hear more about it from Dr. Hasmukh Jain. And he has contributed to the development of guidelines of hematological malignancies, and he has more than 170 publications in peer-reviewed national and international journals to his credit. I welcome you, sir. Dr. Lingaraj Naik has 15 plus years of experience in the field of adult hematology, and he is one of the key experts in establishing and functioning of the BMT unit at TMC Varanasi. So Varanasi, when it started, there was no cancer hospital that was available in the nearby area for the UP state especially. There was no establishment of BMT unit also. It took almost 4 years for the BMT unit to be established and start functioning at Varanasi. So it has been a continuous effort. It is a team effort wherein Dr. Lingaraj Naik has contributed a lot, and we will hear from him about the challenges that he faced and what measures he took and how he and his team has developed this BMT unit at Varanasi to function. So that we will hear from him. So he has more than 70 publications in various peer-reviewed national and international journals, and he is a frequent speaker at various conferences. I welcome you, sir.
Thank you.
So about Navya, Navya is a cancer informatics and patient services company. We leverage technology, which is a AI ML engine, artificial intelligence and machine learning system. So wherein the engine collects all the information of the patient, the clinical data, it is converted into a structured clinical summary, which will be in a chronological order, which will facilitate fast review by the experts to give the recommendation for the next line of management or any queries that the patient or the treating oncologist is having. And we also use this technology to cater to the needs of state government institutions, wherein we use our AI/ML technology to deliver the NCG and NCCN guideline-based recommendations, along with the expert recommendation where there are complex cases. So with this small introduction, I would like to move on to the case presentation. I request our clinical analyst to start the case presentation. Please share your screen and start.
Okay,
Yes.
Thank you. Okay. So our first case is a 57-year-old male, 57-year-old female who had a history of hysterectomy in 2013, presented with a complaint of rashes on hand and stomach, fever in November 2023. Her peripheral smear showed predominantly microcytic hypochromic RBCs. WBC showed 80% of the blast, platelets decreased, Findings suggestive of acute leukemia, probably AML. So she underwent bone marrow aspiration cytology, which showed acute myeloid leukemia with blasts of 70 to 75%. So pathology notes suggest megakaryocytes suppressed, lymphoid and plasma cells suppressed. Peripheral smear on November 17 showed normocytic hypochromic RBCs. WBC total count raised. Differential count shows 60 to 70% of blasts, with occasional cells shows or rods. Platelets 25,000, and findings suggestive of acute leukemia. Further flow cytometry of the bone marrow showed acute myeloid leukemia with 82.59% blast. IHC positive for CD7, CD13, CD33, CD34, CD36, CD38, CD45, CD117, NPO, HLA-DR. IHC negative for CDC 4, 5, 8, 10, 14, 15, 19, 20, 56, 64, cyclin CD3, cyclin CD79A, SCD22, and TDT. Further, RT-PCR and gel electrophoresis showed AML ETO, BCR ABL, CDFB MYH11, TML RARA, FLT3 ITD, FLT3 TKD, NPM1, and c-KIT mutations on exon 17 negative. Risk stratification was favorable. CBC showed hemoglobin 9.7, WBCs 23.5, lymphocytes 8%, monocytes 36%. Renal function test within normal limits, liver function test within normal limits, cardiac function test not available. Functional ECOG score of this patient was 1. General condition is able to do all the daily living activities without any assistance. Symptoms include intermittent fever, weakness, low platelet count. Patient has resource constraint. Patient was planned for aggressive chemotherapy for 2 to 3 weeks or to proceed with bone marrow transplant or passive treatment with oral tablets for 3 to 6 months. Detailed plan of the treatment is not available. Given CD33 positive, role of treatment with standard 7+3 daunorubicin with or without gemtuzumab or ozogamicin versus only with standard 3+7 daunorubicin or idarubicin versus HiDAC versus alternate. Role of bone marrow transplantation now, and role or possibility of oral therapy.
Sir, now the forum is open for discussion. I welcome Dr. Linda Nayak to start the discussion. Sir.
Doctors, the floor is open for discussion. I invite Dr. Lingaj Naik to start with the discussion.
Yeah, am I audible?
Yes, doctor.
Yeah, hi. Okay, so can we just scroll a bit up to just understand why it is favorable risk?
Is this fine, doctor?
Yeah, it's okay. So it's 57-year female and she has an AML. Okay, fine. Go down. You can come down here. Yeah, come down to the question, the queries that they have asked.
I'm sorry, doctor, your voice is a little feeble.
Yeah, can I see the queries? What was the point questions of
queries?
Discussion? Yeah. Coming to so coming to the first query is given CD33 positive, the role of standard 3+7 daunorubicin with or without gemtuzumab machine or with standard 3+7. Yeah, so in AMLs, specifically in a group of AML that is called as core binding factor AMLs, where you have 821 or inversion 16, where we have definite role of using gemtuzumab ozogamicin because their positivity of CD33 is very strong, and that's where the evidence is also there, and that is based on multiple studies and a large meta-analysis where addition of this particular antibody drug conjugate to 3+7 has improved overall survival, but that is limited to only standard core binding factor AMLs. Now, coming to availability in India, it is not available. It is not approved yet. So it has to be imported. So in the real world, the use is very limited. But if feasibility is there and if the drug can be procured, then that can be added to standard 3+7. Now, coming to the question of a role of bone marrow transplant now. So I think first of all, we have to understand couple of things before we decide about transplant in a setting of AML. What we typically do, what we expect, or whenever you do a transplant, our basic intention is to prevent a recurrence in a patient who is in CR, complete remission to intensive chemotherapy, or for that matter in low intensive therapy. So that bargain, when you do transplant, we have a certain amount and which is substantial risk of death due to transplant. And third important thing is that even after transplant, there is a risk of recurrence after you transplant, that is typically within 6 months to 1 year of therapy. So if you know these important three numbers, then only you can take a call whether transplant is required or not. So in this particular patient, it will depend on what is the response that she is attaining after giving standard transplant is suggested. So that decision, I would suggest that we should take it later time point when we get the bone marrow report, the report of the HLA, and also and then the toxicity that the patient has developed. Now, coming to possibility of oral therapy, as of now, it is only used if somebody has received incomplete consolidation therapy, that is which is the standard consolidation is 3 cycles of hydroxytyrosine. But if a patient is not able to finish 3 cycles, in that case, there is a possibility of using oral azacitidine. Otherwise, it is not to be used in all patients who are receiving standard chemotherapy and consolidation.
Right, sir.
Yeah.
Now I request Dr. Asmuk Jain to provide his views.
No, I mean, I agree with what Dr. Lingraj has just mentioned very clearly, that standard would be to give 3+7 induction and consider GO only if there is a core binding factor leukemia. And then bone marrow transplant, of course, to be reserved. So bone marrow transplant is not, I mean, it's something which you can consider now, but that decision has to be taken at a later time point. So yeah, I agree with this. So this question of oral therapy, that would be considered only if the patient is not in a good general condition, where in some sense you could consider venetoclax as an oral therapy and combine it with azacitidine. So if a patient has an active infection or is in poor performance status, that is the situation where you could consider giving azacitidine IV or subcutaneous along with venetoclax, which is an oral medicine.
Right, sir. Any questions from the participants? If there are no questions, I think we can go on to the second case.
Moving on to the next case. Am I audible to everyone? Okay. So the next patient is a 25-year-old male, presented with complaints of fever, August 2023. Complete blood count showed WBC is 49.6, high, hemoglobin 5.5, platelet 63. Further flow cytometry of peripheral blood showed acute myeloid leukemia. IHC was positive for CD11C, CD33, 13, 34, 56, 64, 117 and 123. IHC was negative for cyclin D3, CD4, CD7, 14, 15, 19, 36, 38, CD79, NTD, HLA-DR, and CY-MPO. Pathology note showed acute myeloid leukemia with minimal differentiation. Bone marrow aspiration biopsy showed acute leukemia with 86% blasts. Metamyelocytes showed 0%, myelocytes 0%, neutrophils 1%, lymphocytes 6%, monocytes 0, erythroids 4%. Pathology note findings suggestive of acute leukemia with dysplasia of megakaryocytes. Cytochemistry Pearl stain showed A particulate smear, MPI negative in blast, PSA negative in blast. Cytogenetics karyotyping showed abnormal. Cytogenetic note shows 43XY minus 7, deletion 7, T7, DER9, add Q34, T1113, P15Q10, minus 13, minus 17, 45XY, T3:7, Q27, Q22, minus 13, minus 17, plus MAR1, 46XY7. A source, it's from clinical note. We do not have the original report. Further, myeloid gene panel showed positive for NF1. Pathology note says AML high risk with complex karyotype. Further, again from a clinical note, original report not available. Risk stratification poor or adverse. Patient was started with curative definitive induction, cytarabine and daunorubicin from August 18th to August 24. CBC showed low hemoglobin 7.1, WBC showed 16.3, platelets showed 50. Blast count was 84% on September 7th. Patient was next started on second line of curative salvage, venetoclax and azacitidine from September 6th and currently ongoing. Clinical note says tolerated chemotherapy well, but his counts did not crash. And on day 18 of the chemotherapy, WBC count increased to 19,000. That is about 30 to 40% of the blasts in the peripheral blood seen. Hence, explained refractory nature of the disease and advised HLA workup as he needs salvage chemotherapy followed by an allogenic HSCT. His sister elder showed 12 on 12 HLA match with the patient. On today, day 20, venetoclax, even on venetoclax, WBC count is increasing with 30% blasts in the peripheral blood. Hence, decided to continue with azacitidine and venetoclax and reassess after 2 cycles of azacitidine and venetoclax. CBC not available post that. RFT shows within normal limits. Total bilirubin 1.89. Cardiac function not available. Functional ECOG score showed 1. General condition able to do daily living activities without assistance. No significant disease related symptoms. Patient has resource constraint. Patient desires to know all treatment options. Current plan is plan to complete the salvage chemotherapy for a total of 2 cycles, followed by allogenic HSCT. Elder sister HLA typing showed 12 on 12. Given resource constraint and HLA match of 12 on 12, consider 1 more cycle of venetoclax azacitidine followed by a response assessment for HSCT versus allogenic SSCT now versus alternate. Are any additional diagnostic tests recommended?
Hello, sir. Now I request Dr. Hasmukh Jain to give his expert comments. Please, sir.
Yeah, thank you. So I think this reflects a very aggressive disease biology, and this patient is suffering from what we call as monosomal karyotype because there are multiple autosomal monosomies in this in the karyotype report as shown here. And it is known that these patients don't do well. They're known to be refractory. They're known to be also have very short remissions, even if they go into one. So considering these factors, yeah, it will be very difficult to get this patient into remission. I'll be a little concerned about continuing on azacitidine and venetoclax, particularly when the disease has been increasing, the counts have been increasing while on therapy. Though the options are very limited, and I mean, the fact that there are resource constraints, which is a little difficult to understand when you're trying to like discuss or comment on this very remotely. It could have different bearings, what resource constraint means. But I mean, leaving that aside, I think this is just from a merit of scientific merit and just understanding the clinical course. This is just cladribine based or fludarabine containing regimen like a CLAG, CLI with venetoclax. But the chances or the likelihood that he will go into remission with this therapy is less than 10%. The fact that autosomal allogenic stem cell transplant also don't give good outcomes in such kind of a setting. Those things have to be clearly explained. But if still keen and if is fit enough, then one more cycle of chemotherapy such as CLI when followed by allogenic stem cell transplant is what I would suggest. Definitely not to take up for allogenic transplant with such active disease. So this will be my response. Was there any other question?
Go down.
Any additional diagnostic tests recommended? So I suppose that there's already a next generation sequencing which you have shown, and there's nothing targetable there as well. So yeah, I mean, I suppose I guess that nothing else is going to change this. This is purely a aggressive. This is one of the one of the subtypes with the highest risk of failures.
Thank you, sir. Now I request Dr. Lingraj Nayak to give his expert comment.
Yeah, I agree completely with the comment. So the biggest challenge for this patient is to go into a remission before we do anything with this patient. So as after one cycle of azacitidine venetoclax, this patient's WBC count is rising with increasing blast in the peripheral blood. I doubt giving one more will have anything different in terms of outcome. So in that case, as was said, that you can change to chemo plus venetoclax and then look at whether this patient goes into a CR. If the patient doesn't go into a CR at all, then I guess the discussion about transplant is far-fetched. And I agree there is no additional test that is going to be useful in this patient.
Thank you, sir. Any questions from the participants? Sir, I think there is no questions from the participant. With your permission, I would like to take a slight deviation from the cases and come to your major contributions that you have done to the field of oncology. I think Dr. Lingraj Nayak, you have led the team. You had been a major contributor for setting up BMT unit at Varanasi. So I request your few words on what are the challenges that you faced in Varanasi and how you are able to address it and your approach and the team and the experience altogether. So I think that will give a good idea to our participants about anything if they want to take up in future.
Yeah, so thank you for that question. So this was way back in 2018-19 when we had a hospital at Varanasi. It is called as Homi Baba Cancer Hospital, Varanasi, where this hospital started in around 2017, and the inception started much before that. So hematolymphoid malignancies were one of the commonest malignancy from the Ganges belt, and in that region, though there were hospitals in eastern UP and as a part of Bihar, but none of the cancer hospitals were kind of treating hematolymphoid disorder in large volume. So that most of our patients, if you see today also, almost 70% patients, 60-70% are coming from those regions only. So that was one of the thought to start an active hematolymphoid program and as well as transplant to cater the need of that part of the country. So with that in mind, first challenge was to start a unit from the scratch. So because the hospital that
Sir, you are not audible, sir. Hello, sir. Dr. Nayak. Hello, sir.
when a hospital is
Sir.
being commissioned. Hello.
Sir, in between we lost you actually.
Okay.
Sorry.
Now is it clear?
Yes, sir, it is clear.
Yeah. So first challenge is whenever a hospital is being commissioned, the priorities are different for different because the priority is for the entire hospital. But when you are focusing on an area, then you have to be more proactive to get things done to in the stipulated time, because that is most important when everything is planned simultaneously, be it surgical oncology, medical, radiation. So everything is important. So in that way, you have to also look after your niche area and niche area, and then take it and take proactively to get things done. So second important thing that was important was the training of your ancillary staff. I think wherever all of you are going to work or set up.
Sir, we lost you again, sir. Hello, sir.
To TMH.
Sir, we lost you again.
Yeah, is it clear now?
Now it is clear, sir. In
Okay,
between, we
okay.
are losing you.
Okay. Sorry, I think there is some problem in the network. So what I was discussing is about the training of nurses, which was important. So before the unit conception started, that process was started simultaneously, because that will take time for the nurses were sent in batches so that they can train and come back quickly. And then in the meantime, the lab has to be kind of put in order. That is very important, because you need a good hematopathologist who is going to give you your flow cytometry, your the stem cell CD34 count, so all this laboratory process that takes a lot of time, to get a flow cytometer, to get the reagents, so we started when I went there, we started with the one microscope, and there was nothing beyond that. So everything took time, and with my colleague Dr. Avinash was there at that time in Varanasi, which who took proactive role in getting the flow cytometer in the lab in order in 2 month time. So that gave me a great kind of push to kind of treat patients. Started with an AML. So initially, when you start a transplant unit, you first have to start leukemias and then see how your system is ready to cope up the stress whenever you need. So that is important. So we started with few leukemias, and then gradually, when we thought that we are ready to kind of start transplant, so by that time our staffs were ready, our lab was ready, and the unit was quite well, and that's how we started our transplant. We started in 2018. At first was a myeloma transplant, and then subsequently a couple of lymphoma transplants. Then there was a period when there was COVID and things were shut down all over. So that was the time when we have to kind of stop the transplant program there. So after that, my colleagues from ECTREC, Dr. Anand Kokan and Dr. Sumit Mirk, so they were very actively involved in continuing that unit, and whatever work has been done, it is their contribution. Till now, they were giving time from ACTREC, and they are going there and staying and helping the team there so that the process and the program runs smoothly. So this was a collective effort of everyone, including the lab, our transplant team, and the nurses. So this was the experience, and it was one of the best experience for me as a young clinician when I starting my career, to get that experience. So that will help me in building something better and bigger next time when I am given a job. So with that. Thank you.
Thank you so much for giving us an outline of. I think you would have experienced so many things in the entire process of setting up things.
Yeah.
But I think you have given it the entire gist of things in a 10-minute narrative. I think it requires a lot of more time to explain really what you faced and how the things were taking shape and how you managed everything. And thanks to you, sir. Thanks for sharing your experience. Now I request Dr. Hasmukh Jain to give us speak about his major contribution. That is, I think, the Carticel Therapy between IIT Mumbai and Tata Memorial Hospital. And please now tell us about like how it is making such a huge financial difference, and how the technology is helping, how it is helping the doctors, how it is helping the patient, and your experience. I think everybody is eager to know. With the experience of Dr. Nayak, we learned about setting up things, about the BMT. Now with you, we would like to know more about Carticel Therapy and also the difference between the Western version and the Indian version. Please, sir. Hello, Dr. Jain. Hello, sir.
Hello, am I audible?
Yes, sir. Now you are audible, sir.
Sorry, I lost in between.
Sir, we would like to hear from you about the recent CAR T-cell therapy that you have implemented in between the IIT Mumbai and Tata Memorial Hospital.
Yeah,
So,
thank you. No, yeah. So since most of this is now the whole entire story is mostly in the public domain, and I think many of you are familiar with what the way this evolved. So the preclinical work happened as a collaboration with Tata Memorial Hospital and IIT Bombay, particularly with the Department of Biosciences and Bioengineering, Dr. Rahul Purva's lab. And on the clinical side, we had our for team and also the preclinical work with them, trying to develop the CD19 Carticel therapy, which went through the various stages. That is, initially the development of the CAR T cell, the designing of the gene construct, developing of the CAR T cells, then the preclinical work where it was tested in the cell lines, then the animal studies, then the healthy cells, healthy volunteers cells were collected to generate a CAR T cell therapy product that was replicated in this GMP facility. And with all of this, in roughly 2020, we went in for the application for the first in human clinical trial. And then we started off with the phase 1 clinical trial. So parallelly, both the trials were conducted, the pediatric trial as well as the adult trial. So once we concluded and we established that this product is safe across a wide range, then we went on to apply for the phase 2 trial. This was again, there were two parallel trials that were running at the same time. So this were targeting relapsed refractory B cell malignancies, and again, the safety was then followed by confirmation of activity. So once the activity
sir, we lost you, sir. Hello, Dr. Jain.
As an indication for accelerated approval, and hence the CDSO and the scientific and the subject expert committee granted the approval in October 23, making this the first first Carticel therapy approved in India. And this is how it has evolved, because the entire R&D, starting from the design, the synthesis, and also the clinical trials were done in India, and hence the R&D costs were a fraction of what was what you typically see in the West. And also because since the molecule was developed and synthesized and patented by Indian scientists, it was possible to control the cost of this product. And therefore, as you said rightly, that the cost is 1/10 of what is the cost in the West. Of course, even 40 lakhs places this at a very, I mean, it's still an expensive therapy for most of our patients, because considering all the anti-cancer therapies, it would perhaps be it would rank amongst one of the top few or most expensive therapies available right now. But I mean, at least this therapy is now accessible, and as we go along, hopefully the cost also will come down further, and more patients will benefit. So that is what we are hoping for now.
Right, sir. As you rightly said, this is the first step, and in the first step, the cost has been reduced by up to 10% from whatever was existing earlier. I think it will be affordable to everyone, maybe in the coming days, in coming future. So this is the first step towards that, and I think definitely with people like you and all your colleagues and everyone, I think we will definitely reach that stage of reaching out to all the patients with the affordable care. Thank you for sharing your experience, sir. And I think we have a couple of questions here. Sir, in the chat box, we have a couple of questions.
So there's one question.
Yes, sir. Hello. Sir, we lost you, sir. Dr. Jain?
Or does intent depend on response? If patient can't tolerate standard 3+7, what are the
Sir,
chances of BMT
we
procedure?
lost you in between, sir. Can you please repeat the answer?
So I was just going through the question. I think the question is essentially about what is the comparative effectiveness of Azavan versus 3+7 induction. And I think it is rightly pointed out that currently we are using Azavan only in patients who are considered as unfit for 3+7 induction therapy. So yes, that is the thing. In terms of a straight comparison of Azavan versus 3+7, I think there's a randomized trial that is currently ongoing, which is going to answer this question, at least in terms of responses, and also in some terms, in some way, probably the durability of response. That's so we don't have the answer yet. In our setting, we are using it for patients who are elderly, unfit, in some instances in poor risk AML. In terms of remission rates, though, it seems almost similar. It seems to be closer to what you would expect with 7+3 induction. Now the question is whether this is always palliative. Yes, no, it depends upon the response. And the scenario typically is, for example, if you have a good or an intermediate risk AML who has a consolidation, and because of that you're not able to give 7+3 induction, but you end up giving azacitidine, venetoclax. By the end of 4 weeks or 8 weeks, once the disease comes under remission and the pneumonia is under control, there is a possibility that this patient would become fit for more intense therapy, and that would include BMT as well. So it is not an absolute yes or no situation where once the patient is deemed unfit, he'll remain unfit, except for, of course, the age. Whereas the other factors which makes a patient unfit for induction therapy could change over a period of time, and therefore you can consider curative intent therapy. Dr. Linga, you want to take the...
Yeah, so the question is, can you talk about, am I audible? Am I
Yes,
audible?
sir. Yes, sir. Yes, sir. Yes.
Okay. So can you talk about the indication of BMT and MRD positive patients, especially in refractory AML? Okay. Or is BMT only exclusively done in MRD negative patients? Any case where you have done BMT and MRD positive patient, and can you share your experience? So yeah, so coming to the MRD question. So MRD is done by multiple technique in AML. So the common technique is the flow cytometry. I guess the question is for that only. So we have other ways of doing MRD, it's like by doing a RQ-PCR or NGS based MRD. So my answer will be only specific to flow based MRD. So in patients who are MRD positive, hello.
Yes, sir.
Yeah. If the patients who are MRD positive and they undergo a transplant, so there is data from Italian group where patients who receive standard induction therapy and they remain MRD positive in intermediate risk AML, and if they receive a transplant, their outcome is as good as MRD negative patient. It's a Jimema group study. So that is one such study designed to answer that question, that what will you do in a patient who is MRD positive in intermediate risk. So that MRD positive question is more relevant in an intermediate risk group of AML. In poor risk AML, irrespective of MRD, are going to do transplant. In favorable risk group patient, likely will try to avoid transplant, and MRD question is not that relevant in favorable risk. This question is more important for intermediate risk. Now coming to refractory AMLs, in that case, I guess whether it is MRD positive or negative, transplant has to be done. And if you have a mass sibling donor, or for that matter, haplo sibling, so in that case, if it is a refractory AML, the MRD question is not that important whether to do a transplant or not. But yes, if the MRD is positive pre-transplant, post-transplant, you have to have certain way how to handle or how to kind of prevent relapse, because the patients who are MRD positive pre-transplant, they have high risk of relapse post-transplant. So there are strategies which can be utilized post-transplant, like early withdrawal of immunosuppression, giving donor lymphocyte infusion, which can be used to prevent a relapse where the risk of relapse is close to 60 to 70%. Now coming to any cases you have done MRD in MRD positive, so MRD positive patients transplant, the outcome remain poor, but there is no study which has...
Sir, we lost you, sir. Hello. Hello, sir. Hello. Hello. Hello.
Sorry, am I
Sir,
audible now?
now you are audible, sir. We lost you when you
yes.
were talking about that.
Yeah. So I hope the first question was clear, right?
Yes, sir.
Yeah. Okay. So coming to the second question of doing transplant in MRD positive AML. So we have done transplants in MRD positive patients. And when you do an MRD positive transplant, you expect at least 60 to 70% risk of relapse. Of course, we'll always want an MRD negative patient to do transplant, but the risk of relapses are 30 to 40%. But waiting for a patient to begin to become MRD negative, you may lose that time and the patient may have a frank relapse or where you lose the opportunity to do a transplant. So in AML field, typically we try to attain MRD negativity, but there is no right answer that you should wait for MRD negativity to do a transplant. Transplant can be done in MRD positive patient, provided you have post-transplant strategies to prevent a relapse. I hope I'm clear.
Yes, sir. Thank you, sir.
Yes.
Sir, there is one more question. What is your experience of using maintenance oral azacitidine after achieving complete remission in elderly patient? And if so, how long? Hello, sir. Dr. Naik?
Am I audible?
Yeah, now you are audible, sir. Yeah.
Okay. So coming to the question of role of azacitidine maintenance in poor risk AML post transplant. So there is a study by the Hoven group where this IV formulation of azacitidine was already used in a randomized way and it was not useful. It didn't show any benefit in terms of preventing resistance. So coming to the oral azacitidine, so we have data of oral azacitidine post-transplant study is ongoing. So until unless you know that, we'll get to know better if you get the result of that study. So as of now, we are not using it for our patients as a maintenance post-transplant. Yeah. So Dr. Mir Hussain has the question. So
Yes, sir. And there is a question and a follow-up question. Hello. Hello. Hello.
yeah.
Sir, again we lost you, sir. So there is a question from Dr. Mir Hussain on your experience of using maintenance oral azacitidine after achieving CR after Varanasi in elderly patient. If so, how long? And then there is a follow-up question again.
Yeah.
So if after 1 to 2 cycles of NAs are used upfront in particular clinical scenario like sepsis, low PS, etc. at baseline and there is a CR, want to go with standard treatment of high dose chemo, do we need induction? Do we give induction or go for consultation with that?
Yeah, so I will take the second question first. So what he is basically asking is that if a patient has received because of a reversible condition like a sepsis or a patient is not fit now, but the patient is though younger and attains a CR, so what do you do after that?
Yes,
So my answer will not be based on a good quality evidence, but what I can tell you what I think is if a patient has attained a CR and you have given Aja-Ven a low intensity therapy because of a intercurrent clinical situation, and if that thing has improved, so you should go back and finish your standard therapy, that is standard 3+7 and high dose RRC. Now coming to the question of whether you can just give high dose RRC as a consolidation and not give 3+7, I mean that is a question for research. We do it in couple of our patients based on their tolerance and whether they will tolerate a 3.7 or not. But that is not based on any hard quality evidence. So if I have to decide today that what should I do a patient who is favorable or intermediate risk AML and not going for transplant, if the patient is going for transplant, things are clear. Treatment with chemotherapy only. So in that.
Sir, we lost you, sir.
Yeah.
Yeah. Now it is fine.
Yeah. So that was my answer. I think I answered the second one. The first question is whether you use oral azacitidine in maintenance in patients who what we typically do is you use AJA when, and if the patients are in CR and they have tolerance issues with terms of venetoclax, we stop venetoclax and just continue sub-Q AJA till they respond or till they progress. So we don't use oral azacitidine as because it is anyway subcut and it is not that difficult in terms of administration. So for us, it is more or less.
Hello, sir. Sir, we lost you, sir.
Yeah.
Yeah.
Now
it is audible.
Yeah.
So, thank you, sir. I think this ends the questions that we had to be answered. I thank you for all the time that you have spared, your valuable time, to share your knowledge, experience with all the audience here, the participants here, and clarified their doubts. I thank Dr. Hasmukh Jain for sharing his experience with Carticel Therapy, and I thank Dr. Lingaraj Nayak with his experience on the BMT unit setup and all the knowledge on AML and all the queries that were resolved by both of you. And I request all the participants to please provide your feedback once you exit this meeting. And I apologize for the technical glitch that was there in the beginning and in between.
Yeah.
We'll make sure that we will address those issues in the coming meeting. And
Okay.
I thank all the participants for their patient hearing and active participation. And please provide your feedback once you exit the meeting. Thank you, Dr. Lingaraj. Yeah, I think there is one last question that has come up here. Okay, yeah, it's a feedback. Okay, fine. So there will be a pop-up that will come after the end of the meeting, so you can do the feedback. And thank you, sir. I thank wholeheartedly on behalf of Navya. Thank you so much for sparing your valuable time and sharing your knowledge and experience. Thank you, sir. Thanks everyone for the participation. Bye.